So we have to consider the post-injury cognitive deficits that the person may have, particularly in executive and memory function, comorbid issues with anxiety and depression, post-trauma drug and alcohol abuse, the time post-trauma. And I've put down here high support needs and low psychosocial participation and community integration, because Graham Simpson, my colleague in Australia, has done a predictor study, and those two factors were high predictors of behaviour disorder in association with pre-morbid mental health problems and injury severity to some extent. But various studies that we read in the literature, if we're looking at predictors of behaviour, behaviour disorder, this is the range of variables that people have looked at. But I still think that there's more work that can be done in that area. Okay, the other thing that I would say is that in this area also, we're looking at overlapping symptomatology. So our differential diagnosis is really important. We must think that just because we see a patient who might be aggressive, we don't have a model where for problem Y we automatically apply intervention X. It is not as simple as that, unfortunately. Unfortunately, we've got to take our time to work out, is the reason that somebody is disruptive in therapy because perhaps she does suffer from those impaired regulation of behavioural controls that we've talked about on the earlier slide? And I've seen all of these patients that perhaps they're in pain, perhaps they're fearful of falling, perhaps they're demoralised, they may not like the therapists. And then we have the old chestnut that therapists and doctors not infrequently have said to me in the past, well, she was like that anyway, so let's just get on with things. And there might be other areas. We also have to think about those disorders of drive. Why are they happening? Is the reason that this man sits around all day doing nothing perhaps because he suffers from an organically mediated inertia or apathy? But maybe he's depressed. Maybe he has fatigue. And we've got another old chestnut. He was always like that anyway, so let's just, perhaps discharge him because certainly falls in the too hard basket, and there may be other reasons. Now I'm going to change tack a little now and talk about, in more detail, about what we need to do in the preliminary stages before we start applying the intervention. We need to make sure we know what we're looking at. And this would be a functional behavioural analysis. This is a problem-solving process to determine the reason that a particular behaviour is occurring. So in the previous slide, I had a whole lot of hypotheses in my head that might be accounting for that disruptive behaviour or that lack of activity. So the knowledge that's gained from a functional behavioural analysis is going to help us select the right intervention that's best suited to address the problem. So we have three components. The first one is direct observation. So we've got to get out of our offices, we neuropsychologists, and we've got to go down there to the dining room where they're having their meals, or the bathroom if they're having their showers, or the therapy areas, and we need to look. And we need to take careful account of what's happening just before those disruptive behaviours occur, and what's happening just after those disruptive behaviours occur. So this direct observation allows, we heard yesterday this word, the target behaviour, and this is what we're going to be focusing on very much today in this talk. It allows us to specify that target behaviour. Because it's not enough, if I'm going to have a successful treatment, to say, oh well, we've got an aggressive patient here. What I need to do is, as Wood says, I've got to operationally specify what's meant by aggression. So he's got a whole series of questions. I have to ask, is it verbal or is it physical? Is it directed at staff, other patients, objects? Is it isolated or is it frequent? How long does it last? How severe is it? And sometimes, those behavioural observations are very time-consuming. Alderman and colleagues would perhaps sometimes do time sampling, and that's a way that you can cut down without having to observe in detail for very long hours. I'm just thinking here of Professor Wilson's work when she was developing the WHIM, and what they did was to videotape patients' behaviours that they could then look at afterwards to be seeing what was emerging at what point of time, and that's another possibility that could occur. So this is where I'm going to come back to the overt it's the overt aggression scale modified for neurorehabilitation. So it's not the OBS-MNR, it's the OAS. We're just talking about aggression here, not behaviours in general. So scrub that out of your notes. And this scale has 4 items. So we're talking about verbal aggression, physical aggression against the self, against others, against objects. And each item contains 4 levels. So if we take verbal aggression, for example, the least level for that is that he may shout angrily. That's a non-directed shouting. Right through to the 4th, the highest level is that he makes clear threats to staff, for example. Now, the reason that this, and this is the really innovative thing that Alderman and colleagues have done, is to adapt it so that we can look at these antecedents and the consequences of behaviours. So they've kind of used their detailed clinical knowledge. They've come up with 18 antecedents. So this is the behaviour that was happening just before we've got the disruptive behaviour. So the man's thrown the chair, and we have to think, perhaps was another patient screaming in the background, so it's got nothing to do with anything. Perhaps there was a direct verbal prompt from the staff to comply with therapy. Perhaps the patient who made a request was explicitly denied by staff. So you write down, they've got, it's kind of like a checklist that you can easily just document what was the common antecedent that occurred before that challenging behaviour. And then afterwards they've got 14 consequences, or interventions they call them. So the person's thrown the chair, and what was the consequence of that? Was that aggression perhaps ignored by the staff? Or did a staff member actually go and talk to the patient, say, don't do that again? Or did they have to rush in and immediately give sedative medications by injection to the patient? So having this information and about a whole lot of behaviour incidents will make it very helpful to be doing that first step of a functional behaviour analysis, the observation. So that tells us the facts, what is happening. The next thing is that we have informant methods. So we interview people, the staff, the other relatives, the patient, and we have questionnaires. And this is going to be presenting us with a whole lot of hypotheses about what might be happening to be associated with that behaviour occurring. And then the final thing that is not done very much at all in the neurorehabilitation field, but it's done a lot in special education, is a formal functional analysis. Now, this is a very interesting concept because it takes the form of mini experiments, if you like. And what happens is that those antecedents and consequences are manipulated, in order to understand their effects. And this methodology will allow us to predict the behaviour that's going to occur, why it occurs, and it will also inform us about the type of intervention that might be useful. So I'm going to give an example now. This wonderful paper by Dixon in 2004 gives a very nice example of a formal functional analysis. So we have Eddie, who's aged 61, and he suffered a traumatic brain injury. And the target behaviour that was looked at for treatment was these verbal outbursts, consisting of profanities and threats to staff. And this occurred during his daily physical therapy sessions. So what they did was that they identified 4 conditions: attention, demand, alone, and control. And they were examined in a little 10-minute interval, so not very long, each day over 12 sessions. So in the attention condition, the therapist would respond to the target behaviour, the profanity, with a verbal comment within 2 to 3 seconds, saying something like, "You should not say things like that." Okay? In the demand condition, the therapist would provide a prompt about engaging in physical therapy. In the alone condition, he was placed in a room by himself and he was observed. And in the control condition, he was allowed to sit in the, whatever, recreation area with magazines, and the therapist would deliver non-contingent attention every 30 seconds and provided no consequences for the target behaviour. So in this little mini experiment, here's the results. Now let me walk you through this. The attention condition are these red diamonds, and they're the 4 conditions. So in session 1 we do attention, session 5, session 9. In the alone condition we've got the green squares, session 2, session 6, session 10, and there. In the demand condition we've got the black diamonds, session 3, session 7, session 11. And in the control condition we've got the purple circles, session 4, 8 and 12. I hope it's as clear to you as it is to me what's happening here. Yeah, we've got the answer. The data clearly show that the target behaviour of these profanities was being maintained from escape by the prompts, which is the black triangles to engage in physical therapy that were provided by the therapist. Because you see here we've got the frequency of behaviour, and it's ranging from, let's say, 13 up to, let's say, 18. Whereas these other conditions are all less than 5. So it's a very clear formal functional analysis there. And so the therapy that Dixon and colleagues did consisted of a differential reinforcement of alternative behaviour. So they would train him to be saying, if you need to take a break, please ask appropriately. So they're shaping this kind of very pro-social behaviour. And each response was followed by 30 seconds of termination of prompts. If he did it properly, they would not make any demands on him. But inappropriate responses were ineffective in terminating the exercise, so those demands kept going. And in that way, I haven't got the graphed results, but they were very quickly able to extinguish that behaviour. So that's a formal functional analysis, and that's kind of best practice about what we would be doing before we set up an intervention. Okay. You'll know that we're very big in my research team in looking at, that what we do with our clients, we want to have the best evidence for it. So we need to know what the evidence is for the range of behaviours. And the best way, of course, to do that is to be looking at systematic reviews. And here, I mentioned yesterday about PsychBite. I've taken systematic reviews from PsychBite. Now, Ilvasaka in 2007 looked at impulse control after TBI, so very specific systematic review. He was looking at both adults and children. There were 65 studies and only 2 randomised control trials, one of which, I must say, was done by my student, Jessica Med, and the other one was for children. So that's such a poverty of data. When I read Ilvasaka's review, I was shocked, because I thought that, you know, with all the literature that we have, yesterday I showed you on SpsychBite, we have got something like 650 interventions for behaviour after acquired brain injury. I thought that we would have a much stronger level of evidence. But he said that if you're going to do specific interventions like anger management, it is only a practice option, looking at contingency management procedures and positive behaviour interventions and supports, simply because we don't have enough rigorous research there. But if looking more general, he I think he's fudging a bit here to say it's a practice guideline, but I think he was so concerned about, these behavioural treatments for behaviour disorders being at this low level of practice option. One of my PhD students, Amanda Lane Brown, has done her PhD looking at apathy after acquired brain impairment. And in 2009, we published a study in a systematic review in neuropsychological rehabilitation, where we looked at 28 studies, and we were looking at dementia as well as stroke and TBI. There were 4 studies in TBI, 1 RCT. This is for treatments for apathy. We concluded there is some evidence, but there was not even sufficient evidence to make a practice recommendation. That evidence came from our single case experimental designs for external compensation procedures. And this is where I think the rules have got to change about systematic reviews, because we are so hung up that single case experimental designs don't make it. The Cochrane database of systematic reviews will not include them. Michael was talking yesterday about randomised single case experimental designs being level 1 evidence, so maybe things are going to change. Catalani in 2010, he looked at a broader range of disorders, internalising. We can read here those disorders of drive, externalising, we can read disorders of control, as well as psychosocial kind of disorders like community reintegration. So it didn't really hang together very well. But he's just looking at stroke and traumatic brain injury, identified 63 studies, 5 RCTs. Again, his recommendation is only at the practice option level, and he's saying there's insufficient evidence for the internalising disorders of drive. In 2011, the final one, Bolin, she has looked more broadly at executive functions in her systematic review, but one component of it did look at impulse control. After stroke and TBI, there were 12 studies. The single RCT was again my student, Jessica Meds, on anger management. So she's saying on the basis of that, there is some evidence that treatments to increase self-monitoring and self-inhibition in social situations occurs. When we have such problematic levels of evidence here to guide clinical practice, Guyot and colleagues, who are the doyens of single case experimental designs N of 1 trials from McMaster University, say that we really should be doing a single case experimental design. It should be at that level, because that is the way that we can determine for our patient, has that therapy worked or not. Just going back to Ilvasaka's review then, because I'm just going to, just give you a brief flavour of, just checking the time here, yes, of the kinds of interventions that there are, and this is for both challenging behaviours and, the external and the internal disturbances. Contingency management. So there's a whole group of operant procedures that address the consequences of behaviour: verbal praise, token economies, time-out, response cost. And one of the difficulties with that is that we're not actually skill building in a way that's generalisable. But certainly we can address those target behaviours and either decrease or increase them according to what we want. The second group of interventions he's talking about are positive behaviour supports, and here we're looking at the antecedents of behaviours. And it's very much focused on techniques that are going to result in skill acquisition. And if we have that, we might be able to prevent the disorders happening in the first place. And the third level that he looks about is cognitive behaviour therapies and techniques such as education, cognitive restructuring, self-monitoring and self-talk. Now, sometimes, it's going to depend on the level of disability of our patient as to which might be more appropriate as well. So I myself would never dream of doing a cognitive behaviour therapy with somebody who's got major memory problems and executive disorders. It might be, and who also has challenging behaviours. It might be better to be looking at contingency management or positive behaviour supports for such a person. So here's some examples of contingency management, NIGHT. They looked at the differential reinforcement of low rates of responding. What they're looking at in their case MA is a person who was making these provocative verbal comments, and so they're trying to reinforce that if he does less than a certain number of these provocative comments, he will get his reinforcer, whatever that happens to be. Alderman, he's looking at an example. He's published a lot in the literature about a lot of different interventions. His work is very good, and it's, I recommend that you follow that if you're wanting to know more about this area. One of the perhaps more controversial interventions that he looked at is satiation through negative practice. And in his case, JA, this man shouted a lot. And what you're doing there with these kinds of procedures would be, in fact, when he shouts, you encourage him, when he stops, to shout for another 2 or 3 minutes. And, it's a kind of a positive punishment procedure. It is effective, but it does certainly have ethical concerns. And I think we would all agree that if you can be doing something that's going to be less intrusive, that is more positive, that will be advantageous. My view also is that, many of our clients, they don't like the way they are. They've found themselves in an aversive situation, and I think I gave the example yesterday of that young girl who, my response was to get her out of the unit and deal with her depression rather than, kind of trying to ameliorate the behaviour at that point in time. Now, Zenkius, you're going to look at that 1989 and think, what am I doing here? His work is marvellous. So he comes from a group in the United States, and I don't hear anything from him anymore, but in the 1980s and 1990s, he's got a wealth of single case experimental designs that have all sorts of different kinds of interventions. Here, one of them is behavioural contracting. So, you earn points, and if you earn enough points, then you can have your preferred activities. And he did this in a couple of cases to increase their attendance at therapy. Now, Knight, who comes from Alderman's group, have looked at a compare and contrast about 3 different types of interventions. This differential reinforcement of low rates of responding, response cost. Now, this is something where you might be given a number of tokens, for example, at the beginning of the day, and you've got to maintain them. And if you engage in any of those target behaviours, tokens are taken away from you. And then self-monitoring training. So they're saying that, so the strategy that is used will be positive reinforcement, the response cost, negative punishment. We're not so interested when we can be looking at positive reinforcement. We all agree. Again, response cost, like that satiation through negative practice, it's got some ethical issues there. And, you're taking things away from people. DRL and self-monitoring training, they're less intrusive, and they also build skills approach. And we want our patients to go away not just having the absence of the undesirable behaviour, but actually skills that they can carry through later on. Whereas response cost, that can be seen as degrading. Oh, you did that problem there, give me a token, The thing is, though, that treatment gains, the literature suggests, are much more rapid with response cost than they are with self-monitoring training. The good thing about self-monitoring training that we don't see in the other 2 areas is that treatment gains may generalise to new environments. And of course, that's a crucial thing that we want to be doing when we're looking at our behaviour interventions. So there's pros and cons about all of the areas, but looking at the literature, self-monitoring training, if the person has, kind of got the cognitive skills to support that, or the DRL, there's lots of studies of that in the literature. A couple of examples of looking at antecedent controls. So this is where we're trying to get in there in the first place so that we can prevent the behaviour. Weslowski, and he comes from Zenkias's group. So he's also in that group of people in the 1990s who have done such marvellous work. They developed the concept, and a lot of these things, that's common sense. Mini breaks. So they were in a vocational rehabilitation setting, and what they did was to give their patients who were taking these unauthorised breaks, they'd just walk out of the therapy area, every 10 minutes, every hour they would get a 10-minute break. And then they were able over the course of time to extend that. Feeney and his colleague who's now passed away, Mark Ilvasaker, have also done excellent work in looking at these antecedent controls. And they do wonderful things like they have these prepared scripts that they train their patients and sometimes the staff also to be saying. So the scripts might be, I need a break, or this is going to be hard for me. And by having these kind of scripts, they were able to reduce challenging behaviours. In some cases, these were adolescents in a school situation who would be pushing and hitting and threatening. So very effective. So there's no lack of interventions, is the message that I'm wanting to give here, to be looking at our challenging behaviours. I've talked about anger management training. Again, this was published again in Neuropsychological Rehabilitation, our flagship journal, in the year 2000. There is still to be a second RCT reported. Tessa Hart has done a case series, but of course a case series does not have controls, and so we can't really make cause-effect relationships that we can with a randomised control trial. Now this was small, 16 patients, so we had eight in each group. And what we looked at here was, it was a manual based, and it's based on Novako's work. So it's based on work that comes from the, the general clinical population who don't have brain impairment. And so we need to adapt any of those treatments that are used with those kind of clinical populations without brain impairment. We need to adapt these in our work here. But going around the posters, as I've done over the past couple of days, I've seen lovely evidence from your teams here where, you certainly do that in the course of your clinical work, so that's really good to see. But this program, it starts off with psychoeducation. Professor Wilson's already talked about the importance of understanding brain injury and the causes of anger in this case. We present a model of anger. And then a very important stage is increasing awareness of anger. So the ways that we would do that is by getting people to do little rating scales of when they have an anger outburst. How angry was that? And indeed in our follow-up sessions they say that that's one of the most helpful things to them is to have these little rating scales. So it's a little bit like a thermometer, and that they can start to be monitoring their level of anger and distress. And then the fourth component of that kind of program will be training in strategies to overcome anger. So relaxation, if people are getting very het up, self-talk, cognitive challenging, assertiveness, distraction, time out. And in a sense, people can have these, they've got a menu of strategies and they can be choosing whatever is best in a particular situation. The treatment here was 5 to 8 hours, very brief, but it's intensive. It was individual sessions over 5 to 8 weeks, so it was an hour a week. Now these were people who, unlike the kind of cases that we have been seeing over the course of the past 3 days, they were able to be involved in this cognitive behaviour treatment. And the results were that the treated group improved significantly more on the STAXI, which is an anger questionnaire, than the non-treated group. So nice evidence that this intervention indeed works with this kind of clinical group. Unfortunately, there was no transfer to mood or self-esteem. And when I'm reading the literature, I often see these kind of comments. We often build in these additional measures to see, will there be transfer effects? I don't necessarily think that an anger management program should necessarily improve self-esteem. I would be hoping a self-esteem program would be improving self-esteem. So I'm never terribly critical of studies when we don't see those generalisation issues. To me, that doesn't detract from the quality of the study. What I'm interested in is what's that primary outcome variable? It's anger. Did the anger improve? The other issues are very nice to observe, but they're not fundamental to answering the question. And that's just a graph of the results. Now, let's turn and look at apathy. So the converse of our disturbances of drive and control. And here we don't have, there's no RCT. Well, there is an RCT that my student identified. Some kind of wacko treatment it was. I've forgotten what it was. It was irrelevant. The people did not even do between group differences. They just looked at within group differences, so it doesn't even tell us whether the therapy works. But what we have is very rich literature of single case experimental designs. Now Burke, who's again a colleague of Zinkius, he looked at Jack. And in fact, this is a nice example, isn't it, of, what we're going to be looking at here is Jack's problems with initiation. That's in these disorders of drive. He can't initiate, he has this apathy. But look at what else he's got. He's got problems with concentration and memory and monitoring and egocentricity, they say, this comes from their paper, social judgment, insight. Anyway, the setting is, you know, a lot of these people also, they do it in context, which is very nice to see. So it's a local restaurant in the kitchen and pantry areas. And what they're targeting is the number of cues that he needs. Okay, Jack, now you need to fill the pastry cases with the jam. You know what it's like with patients who do not have that capacity. You know, they say to me, my get up and go has got up and gone. You know, they need that prompt and structure the whole time. So that was the target behaviour. They were wanting to reduce that. And he was provided with a simple checklist of 9 daily tasks that for completion. And he used the same tasks, the same order. On day one, he's provided with a rationale for the treatment. I mean, this simple treatment. He was given a demonstration, modelling of how to check off the checklist each time he did the various tasks, and how he had to look for the next task. And on the next Monday, he was provided with a new checklist. And look at that. You would think I made these data up. In our baseline, he's requiring 3 or 4 cues. So this is the baseline before we start the intervention, and when and as soon as we introduce the intervention, perfect. When we take the checklist away, now we might think that's an external aid if we're thinking of Michael's talk yesterday, and there was a very interesting question that came from the audience about this very thing. What if the behaviour doesn't revert back to baseline? And in a sense here, we don't really have a very good demonstration that it was the checklist and nothing else that worked. But I think what's happened here, he has internalised this strategy. He's got his own checklist in his head now that has become a strategy. It's not just an aid, and in a sense we can't take it away. So we've got this blip here. We don't worry about that blip because, you know, we've solved the problem. External cues as a treatment for apathy. Now here we've got a study from John Evans from Professor Wilson's group, and what they've got is a single case design. This is up here, a 50-year-old woman, I think. Right, so there she's 7 years post-stroke, and on her CT scan we've got all sorts of ischemic changes there in the frontal lobes. And again, we're seeing that she's not only got this problem of the inertia where she's requiring prompt, but she is distractible and she's disorganised and she's got some obsessive compulsive type behaviours. So we're using NeuroPage as a prompt. So NeuroPage is often used for people with amnesic disorders to assist them with their memory, but it's been also used a lot with disorganised behaviour. It's used as a prompt. She's got to take her medications, water her plants and wash her underwear. And they used a very nice reversal design here in the A condition before she's got the NeuroPage, B where she's using NeuroPage, and here we do see, don't we, not a reversal to baseline, but certainly when we take away the NeuroPage, the performances are not as good as when she's got it. And we've got a nice second B phase there, so that clinches it for us. Yes, it's NeuroPage. So I'm just going to, I've talked about PsychBite yesterday because I want the clinicians in this audience to use this resource. It's a wonderful resource, and I'm going to show you how you do it. It's so easy, like in, 5 seconds less, you get the answer. This is the home page. So you click up there on the search button and up pops the search page. And what we have are these drop-down menus. Now, I'm sorry you can't see this, but when you will on your PowerPoints when you get those. But here we've got the treatment group, the neurological group, and we've got about 7 of these groups. So I can just use the drop-down menu to look at traumatic brain injury. And then, like that. Then I go down here to the target area, and I might be interested in behaviour problems. So again, I click on that on the drop-down menu, and we've got, 30 different types of target behaviours. And I can select all sorts of other things. If I just wanted to look at adults, I could do that. If I wanted to select a particular type of intervention, I could do that. If I wanted to look at a particular methodology, I could do that too, but I haven't here. I've just done those two things. And then, having done that, I click on that search button. And up pops all of the trials. So this is the results page. Now you can't see here, but I'm going to tell you that up pops 172 interventions for behaviour disorders after traumatic brain injury. Now, the best thing about this database is that here we've got 172, so it's spread there over something like, whatever that is, 17 pages. And here I'm at page 3, because the first 2 pages are systematic reviews. Because what we do in this database is that we rank order all of the results in terms of method strength. So not by author, not by year of publication, but by method strength. So all the systematic reviews are first, all the RCTs are second, all the but controlled clinical trials are third. And even better is that over here on the left-hand page, for all of the primary studies, we rate their methodology scientific quality. And so we can see here, and they're ranked on the database. So the top, we use the Pedro scale for group studies. We've got 8 out of 10 is the best, so that goes number 1. And so it goes down. And here's the Med and Tate study down there that scored 6 out of 10, and we've got some studies in between. So we've got, kind of like 17 pages worth of that. And so then you can go down and you can look at what might be useful for your particular patient. So this study here that scored 8 out of 10, very good method quality, but it's about children. So I think, I'm more interested in adults. So I wouldn't click on that to have it bring up the source and the abstract. So, in summary, there's vastly more information available for interventions to treat poorly regulated disorders of control than there is to treat deficiency in behaviour, the apathy and the other disorders of drive. And so there's a huge need to increase the knowledge base of the latter. Now, the literature on interventions for challenging behaviours is largely single-case experimental methodology. And in general, when we rate those, because we rate those with, Michael talked yesterday about our risk of bias in N of 1 trials scale, they're good, they've got good scientific quality. Now, although much of the literature is old, and I've already talked about Zenkius's group in the US, I don't think that matters in one sense, because the principles that they've got in those studies, they provide a really valuable heuristic for trialling or adapting various treatment approaches for the patient who might be in the hospital, in the clinic, in the community. And PsychBite provides that wealth of systematic reviews and primary interventions for the management of challenging behaviours. So we've got a lot of information there. So given that a single case approach is what is accepted in this field, and much of the evidence has been provided by clinicians, so Alderman's a clinician, Zenkius is a clinician, Ilvasacker and Feeney are clinicians. They're not researchers, well they are researchers, of course they're researchers, but then they're not like me sitting in the ivory tower of a university, they're in the clinic. And they're designing high quality studies for their patients. The practising clinician is therefore in an excellent position to conduct and publish work from their clinical practices. Now, yesterday I was talking about the MATE, and we talked about the Robbins scale as resources that are there for you to design good quality and publishable SCEDs, and I end my address by urging you to do so. Thank you.
Thanks for the lovely presentation. Any questions from the audience?
Hi. That's regarding your SiteBite resource on the website.
Yes.
I was wondering when all the research, all the studies show up, are they only abstracts or you also get the full text?
No.
Because we have got a huge difficulty getting full text articles, you know, or...
Yes, well, I'm sorry about that, but that's it, yeah. In fact, there's a whole lot of, we can't even get permissions to get the abstracts. We've got permissions from Neuropsychological Rehabilitation and a couple of other journals, but what we've got is links to Google Scholar, and you can get the abstracts that way, and then you have to go onto PubMed or something. Sorry.
Okay. No, thank you very much.
We would have, except it's the what's that word? Permissions issue. We can't get permissions. Yeah.
But it still looks like very wonderful, you know.
It is.
Yes. Yeah. Thank you.
Excuse me, does the database contain data for so-called functional disorders like schizophrenia, OCD, etc.?
Very sorry.
Does that SiteBite data contain information or data related to schizophrenia and other functional psychiatric disorders?
Yes, it's only for brain impairment. So we don't have psychiatric disorders. We would like to extend it to all of mental health, to be quite honest, but we don't have that. We don't have developmental disorders either. So it's really just about acquired brain impairment. Yes.
Thank you.
Thank you for that excellent talk. I was very interested with the analysis that you did with Eddie in the beginning of your talk. The behavioral analysis that you did with the patient Eddie. I was wondering, was that done for 10 minutes each session? Was that on consecutive days or was that in one day?
Yes, no, so that's not my work, that's Dixon's work. What he seemed to do was to be doing like the attention one day and, well, one session. He doesn't actually say whether a session equals a day, so I'm not sure what that means. Maybe a session, one in the morning, one in the afternoon, I'm not sure. But yes, no, they didn't ever do the two things in the one session. It was kept very separate, yes.
Thank you. This is more a general question to anyone, is how much do you all focus on follow-up? And do you do regular follow-up with patients after they complete some sort of rehabilitation? And who does the follow-up? And do they come back, or is it just done over email or telephone?
Well, the system that I work in, yes, follow-up it's critical. It's critical. In fact, that's how I learnt my neuropsychology. That's how I learnt my traumatic brain injury, is by having patients and their families coming back as when they're in the community and seeing what the problems were. Yeah. Mm. So, shall we move on to the case? Yes. Yes. Okay, so I now have the case presentation. Yes. As I say, I've been very impressed here listening to the strategies that used to adapt treatments for people with traumatic brain injury. But just for the record, I think I need to include that. So in terms of the structure of sessions, with people who've got, any ABI, really, it's not even a traumatic brain injury, but we do need to reduce the load on attention, concentration and fatigue by including breaks within sessions, and also by pacing the rate of introduction of new material. In terms of the content of sessions, again, we need to reduce the load. We need to reduce the load on executive impairments by providing concrete behavioural learning strategies for them, by having simplified explanations, and by activities that are in a structured format. And we need to build skills. And the way we're going to build skills is by repetition of material and opportunities outside the clinic for practice and rehearsal. and patients benefit from direct corrective feedback of their performance. And we need to have supplementary material. So whatever manuals there are, we need to have more. We need to address those memory problems by providing written aids during sessions that are handouts and worksheets, by summaries of topics covered in sessions, workbooks or other recording format that provide a permanent record. So they're just kind of like the game rules that I have in my head when I'm doing therapy with patients. And now I'm going to talk about this case of a person I'll call Greg. Now Greg was a terrifying man, actually. He was a 27-year-old biker, or bikie as we call them in Australia. He was full of tats and muscles, and, well, he didn't have muscles by the time he came to see us, but the tats were still there, tattoos were still there. He's married, and he was married, and he had a 2-year-old daughter. He had limited education and long-standing unemployment. Now, he sustained extremely severe traumatic brain injury and orthopaedic injuries in a motorcycle accident, and he was in coma for some weeks. So the CT scan, we've got midbrain and basal ganglia hemorrhage on the left, diffuse cerebral edema and cortical atrophy were also evident. Now, as if that wasn't enough, I think the thing that really set the scene for Greg's rehabilitation was the fact that this severely disabled man spent the first 11 months post-trauma nursed in isolation due to a series of multi-resistant staphylococcal infections. So he came to the rehabilitation unit where I was working at 12 months post-trauma. And he had severe physical disability with a right hemiparesis, marked dysarthria and no speech at all. He was able to follow simple commands. So that's the level of the assessment that we're doing, is to be working out how much is he understanding. He, as I say, there was no speech. He could hardly move, except he could certainly swing his good arm to engage in extraordinary behaviours. So he was aggressive, verbally and physically, which he exhibited whenever he was approached. And what would happen is this man would scream and bellow is the word I use. If anybody came in proximity to him, he would grab them with that good arm, that good strong arm, and he would hit nursing staff whenever physical contact occurred. And you can imagine, with a man with this level of disability who could not even feed himself, how much physical contact was required with the nursing staff. And we're not even thinking about therapy here. So these behaviours would happen whenever he was transferred, washed, dressed, fed. And not only that, anything that was put in front of him, like plates of his food, urine bottles, he would throw them. So, he was extremely difficult to manage. And at this point post-trauma, what was his discharge plan? I mean, he's only been admitted, but we have a discharge plan. And that was, his wife could not manage him. She was a frail little thing. And so it was, unfortunately, that he would need to be discharged to a nursing home. In Australia, we don't have nursing homes for young people. All the people in nursing homes is for elderly people. So it's a very unattractive environment to discharge a young traumatic brain injury to him. Now, the nursing staff requested my assistance in managing his daily routines, and I have to tell you, I was very pessimistic. But, as Professor Wilson says, always give it a go. And I was frightened of this man, to be quite honest. Just moving quickly to the management plan, what we did was to look at differential reinforcement of his behaviour. So I used tokens and I used time out. And so we've got to start small here, So we're looking at what's the minimum we can do. So we need to, I talk a lot with the nursing staff about, what would be good things. I also talk with the family, even though this is kind of more a nursing intervention, I talk with the therapists. But anyway, it's grabbing and hitting people, it's throwing things, and it's this screaming and bellowing. And we thought, okay, well, slowly does it. Let's just look at 2 situations. So we're not looking at the whole day. I'm just looking at when he's eating and when he's being transferred. And we'll give it a go. And this program was initiated very quickly after he arrived in our rehabilitation unit, kind of within a month. And during that month, what am I doing? I'm observing, I'm talking with the staff, I'm trying to get it right about what it is we're going to do. And I'm also seeing Greg. Now, he was positively reinforced with tokens if those target behaviours did not occur in the target situations. And at the same time, he was negatively punished with the removal of to the time-out room for 5 minutes if those target behaviours did occur in the target situations. Now, selecting the reinforcers, you can imagine we've got this very disabled man there who I'm not even sure he can understand when I talk to him. And here we are in my office with the door open. But I love this bit. I love the bit about selecting the reinforcers. But it's also the biggest challenge I find, because what I want to get is what's just right for this person. And so I'm racking my brains to be innovative, to be thinking what could be the possible reinforcers that we could use with this man that's going to be effective. And, I'm thinking bikie magazines and, and we have all of this. So I kind of acquired all of these things, and I spread them out on my desk, after some time, and I get Greg in and I say, choose what you'd like. And I thought, well, here's a guy, we're going into the 2nd year post-trauma, he's still in hospital, he's a bikie, I reckon he would like his beer. And his wife said, yes, he would like his beer. So I had to negotiate with the medical director that it would be okay to use some beer. So, in fact, and that's what he went for right away. He chose that we had this conversation, as I say. I'm not sure whether he followed it or not, but he certainly was able to indicate that he'd like the beer. So if he got sufficient number of tokens, he could have that at the end of the day with his evening meal. So what we did with the nurses, we looked at 17 daily target situations that we thought would be amenable to a behaviour program. And so they're things like the morning shower, when he's dressing, the toileting, eating breakfast and so forth. Now, the nursing staff were trained, so in this situation, I am the boss. I spend a lot of time with nursing staff trying to get it right. I spend a lot of time saying, okay, well, these are my ideas, but do you think they're going to work in this situation? So we negotiate and get it right. And for this man, I was actually able to get from the director of nursing extra male staff onto the ward, because we wanted the male nursing staff to be doing this program so that the females would not be intimidated. They're also trained like how to approach him, okay? And so one of the things is about, kind of letting him know that something's going to happen, because he finds this aversive, anybody approaching him. So we said, Greg, now I'm going to put your breakfast tray down. Greg, now I'm going to transfer you. As well as increasing pleasant interactions in general, because you can imagine the number of pleasant interactions this man had had in the previous 13 months. They're also trained how to record behaviours. So once we're all in agreement, the program has to run by clockwork. At the end of day 1, I say to them, we have meetings every day, of course, what do we need to change about the program? Is there everything going okay? So, as I say, I'm the boss, I'm the one in charge of changing the program if we need to. So they're very flexible. But when they run, they need to run perfectly. And to my great surprise and everybody else's, there was an immediate improvement in these target behaviours. And so it was really possible to upgrade his program and also to include additional target behaviours. So we looked at, the bathroom, and his token system was also reviewed. And so now we've got more behaviours, and he's only allowed to lose 3 tokens before forfeiting his can of beer. So I have to kind of explain this. But there was not really an issue. We had this 2 months the program was in operation. Now this is not a huge impost on the nursing staff, because this then becomes the way that they manage Greg. It just becomes, this is their routine. What they're doing is doling out the tokens. It is not time consuming, but they're very systematic in the way that they interact with him. We saw that there was really good reduction, although not total absence of the target behaviours. And at this point, the 3rd stage of the program was introduced. Because what had happened is that Greg's screaming and bellowing had been replaced by these it was soft grumbling and growling noises in the target situation. So, this poor man, who still can't communicate, we'd had the speech pathologist involved to be seeing if he could get an alternative communication system, but he had been unable to learn how to use it. So by this stage, we're knowing that he's got major cognitive impairment, if we didn't know that before. But anyway, we give it a go, these soft growls and grumbles. But after 4 weeks, the program was abandoned because there was no success in the amelioration of those behaviours, and they averaged about a daily occurrence of 5. Now, what I've graphed here are so this is all of the target behaviours. So by this stage, we've got quite a large number of target behaviours. We've got the screaming and the bellowing and the, throwing and the hitting and the grabbing, as well as the soft growls and the grumbles. And so we ceased the program there, and 2 months later, I did a follow-up with him. And what we're seeing here this is what I'm most interested in, because this is the behaviours in stage 1 of the program. So it's averaging these, hitting, grabbing, bellowing, really quite a low incidence for such a man who is so severely disabled. And the kind of idea was that, we'd given it a go about the soft growls and grumbles. It didn't really worry anybody, so we just left it. And, the good news was, if you could call it good, let's call it good in inverted commas, but he was able to be discharged to a nursing home. So I guess that's the case. And the take-home messages, I guess, here is that I think one of the principles we always need to keep in mind is about least restrictive practices. And I worked with a wonderful team on this ward, and the nurse in charge, if we had difficult behaviours with 2 patients who didn't see eye to eye and there was major verbal and physical aggression, she would do things like change the beds, so that rather than them being in 2 beds together, we would separate them so that one was in a different area of the ward to the other. So I think it's always important to do what is least restrictive first before we ramp up to these kinds of programs that I'm showing here. I think it's really vital that these are, we work in collaboration with the patients and the family and the staff. So it's never me coming in and pontificating about how a program should be set up, but rather it's a journey that we all share. And I think one's got to be innovative. And as I said, I love the stage where I get to sit down with the patient, having got it all in my mind, and we're there ready to look at what those reinforcers would be. So, I remember working with quite a young boy, actually, of 12, who was admitted to our unit, even though that was because there were no paediatric units.